Thank you, everyone, for joining us today. I think we have a quorum, and hopefully a few more will join us. This is the day each year. Okay. Let me talk about the upcoming schedule first. Today is our CROI 2022 review. Eileen is going to be doing the bulk of this, and if there's time, I may add in a little bit as well. Next week, we are canceled. There's a DOM, Department of Medicine retreat going on that starts in the morning and ends at around 4:30 in the afternoon. And we encourage people to go to that, just as the department has been doing that. On the 25th, we will take back up again our 31st annual clinical care of the patient with HIV and hepatitis seminar, and Dick Chason and Richard Ambinder will have updates. And finally, April 1st, solid organ transplantation and HIV lecture that Christine Durand will give. So without further ado, let me turn this over to Eileen.
So Richard, are you looking at my sorter or the actual screen?
The actual screen, thank you.
Okay, great, awesome. So great, so we have a rapid review of some things from CROI. And so I'll start with this sort of least applicable to daily lives, but very interesting topics. So the potential of another case of an HIV cure. So this was covered in the session back on Monday that highlighted a lot of the Hopkins presentations, but just couldn't not mention it. And Debbie Prasad is one of the main team members for this study. So what was this study? It was about a woman who was potentially cured after a novel stem cell transplant approach. So there's 2 prior cases of medical treatment associated HIV cure. There's also cases of what appears to be spontaneous cure in at least 1 female. But the Berlin patient, Timothy Ray Brown, who passed away in the last year from an unrelated cancer, and the London patient, Adam Castillo, both of whom received allogeneic CCR5 delta 32 deleted bone marrow transplants. And so CCR5 is one of the co-receptors for HIV, as we all know. And when CD4 cells don't have that, they are resistant. So by replacing the marrow with these resistant cells, the hope was that this would lead to cure. So both of these patients had significant graft versus host disease after the treatment, and that was one of the possible mechanisms for how it led to remission. And there were questions about the specifics of the conditioning regimen. So these very broadly immunosuppressive treatments that people have prior to bone marrow transplant. So then the next question is, why only 2? So if we know this works, there are plenty of people living with HIV who have cancers, and many of whom may require stem cell transplantation. So there's a scientific issue, which is that we really don't know whether it's specific features of the HIV reservoir or conditions associated with the treatment that were led to the remission in these 2 cases. And then there's also a very practical problem of identifying matches with the CCR5 deletion. And this is a particular problem when people are from mixed ethnic backgrounds, for which matches can be harder to find. So what happened here? So this was Impact P1107, which was initially a pediatric trial, but they were co-endorsed by the ACTG, and trying to use a novel approach of combining cord transplantation, which is easier to find a match because you don't have to match on as many HLA alleles when you use umbilical cord stem cell transplant as opposed to adult stem cell transplant. And the problem with cord transplants is that they take a long time to engraft, which leaves patients with a risk period that's prolonged. And so one of the strategies is to mix this with a half-matched adult transplant. And so that's what was done in this protocol. So the patient characteristics of this particular woman, she was a middle-aged woman. The definition of that shifts as I get older, but I don't know what it was in this case, who was diagnosed with HIV acutely about 4 years prior to developing high-risk acute myelogenous leukemia. She was started on treatment relatively close to her time of diagnosis. She got reduced intensity conditioning, so not as severe as the Berlin patient, for example, and then got the CCR5 delta 32 homozygous haplocord stem cell transplant. She got full remission of her AML, which is the primary goal of the treatment, and 100% chimerism of the donor cells, meaning that she only had donor cells detectable at day 100. And she actually had no graft versus host disease, which is an important scientific addition to the understanding of this process. She did have some asymptomatic reactivation of CMV and EBV, but without major pathology from that. So prior to transplant, she had normal measures of her HIV reservoir, and I've got the numbers here, but she, on the bottom line is she had detectable HIV DNA, she had detectable low-level HIV viremia at about 3 copies per mil, and an inducible reservoir that was measured in the range that we would expect. And then after transplant, almost all of that went away. There was transient detection of HIV and genetic material a few times, but not frequently. She became HIV antibody negative, and she has no T cell responses to the GAG protein of HIV. So basically looks HIV naive. And at 37 months after transplant, after a discussion, she interrupted her ART. And at the time of the submission of the abstract, it had been 14 months, but she has now persisted out for 16 months with no detectable HIV rebound. So stem cell transplants for everyone. So still only for patients with separate medical indications for treatment. But I think this case is really, it's an amazing addition to what we know already. And there's some important scientific questions that are potentially answered here. The role of GVHD did not appear to be necessary. So the graft versus tumor effect is sort of also in this same family, the idea that maybe the transplanted cells actually clean up some residual tumor, or in this case, residual HIV reservoir, but wasn't necessary for her. Her conditioning regimen didn't have, the myeloid cell depleting agent that the Berlin patient had, and a couple of other features that make it interesting as we try to piece together what is actually necessary to achieve this goal. And it also potentially expands the pool of donors with haplocodes that could make this type of treatment available for more individuals, which it's still going to be a very narrow group, but again, important scientific things. And if you are so unlucky as to develop a tumor, might you be more lucky to actually be cured of your HIV? Seems a little bit more feasible with this approach than finding perfectly matched adult stem cell transplants. So other things from the HIV Cure sessions that I thought were of interest or potentially of note, Debbie also led a study of very early treatment in infants, which is the IMPACT P1115 study, basically trying to recreate the story of the Mississippi baby that many of you are familiar with, who appeared cured after very early initiation of treatment, although then subsequently had rebound. The bottom line was that with a very early treatment initiation protocol, about 1/3 of the infants met their virologic criteria for having enough suppression and low levels of HIV reservoir and activity that they might have been eligible for an interruption. I think this study was important for 2 reasons. One, from the cure perspective, but also just for the establishing the feasibility of getting infants treated immediately in the global setting. This was conducted mostly in sub-Saharan Africa. And I think that that's really an amazing contribution in just demonstrating what we can do with the will to do it. And as we all know, early treatment is beneficial for the immune system in many ways. And I think it was a really important demonstration of that feasibility to do that for infants in the global setting. And then finally, there was the other one I found most interesting was a clinical trial looking at broadly neutralizing antibody in combination with a latency reversal agent. This was a trial done by the Danish investigators that enrolled 60 people to either continue on antiretroviral therapy alone, to be given treatment with this 3BNC117, which is a CD4 binding site antibody, to be treated with romidepsin, or to be treated with antibody and romidepsin. And those last 3 arms all had ART in addition to their treatments. About half of the patients had been infected for less than 6 months, so also looking specifically at sort of acutely infected patients by that definition. And the bottom line was that if you add in an antibody, you did reduce the number of productively infected cells that were measurable. And the importance of this particular study, I think, is we're going to see more studies trying to combine immune interventions with latency reversal, and in particular antibody-based treatments, because they're so well tolerated as compared to some of the other immunomodulatory treatments. So just to round out HIV Cure, I did want to mention that there was a really beautiful symposium from our very own Francesco Simonetti. So if you have the time to look at that, his talks are always fantastic, and this one was no different from those, as he discussed how the selection pressure and immune system responses shape the HIV reservoir. Okay, so let's come back to Earth from HIV Cure Horizons and talk a little bit about the ANCHOR study. So the ANCHOR study has like some of the best promotional materials I've ever seen, where so this is a screening study looking at anal cancer prevention, and all these butts become anchors, and there's music, and it's very cute, and also just very clearly introduces what the study is trying to do. It's really, like, to me, the best example I've ever seen of study marketing. So this is protocol 801 from the AIDS Malignancy Consortium. What did we know previously? Well, we know that anal and cervical cancers are preceded by the development of high-grade squamous intraepithelial lesions, or HSIL, and screening and treatment of cervical lesions is well established for prevention of cervical cancer. We know this. Pap smears and then colposcopy and then treatment of lesions is well known to be efficacious for prevention. So the fundamental question that this study was addressing is, does screening and treatment of anal HSIL in people living with HIV reduce the risk of anal cancer? And the study intent was to determine whether HSIL treatment was effective, to monitor the safety of these treatments, and to collect samples to work out the biology later. And all of this data is from a special session, Abstract 104, which is presented by Joel Polewski on behalf of the Anchor study team. So what did they do? So people living with HIV who were more than 35 years were screened with high-resolution anoscopy, and this is a really critical point. That's how they screened them. They did high-resolution anoscopy of 10,723 people across multiple sites in the US. They identified people with high-grade lesions already, so with HSIL on anoscopy, and of those there were 4,446, and enrolled them and randomized them one-to-one to either have their high-grade lesion treated or to undergo active monitoring, which is repeated high-resolution anoscopy over time. The study was actually stopped early because of a dramatic difference. So there were 9 individuals who progressed to anal cancer in the treatment arm and 21 in the active monitoring arm. This was a higher incidence than they had predicted and even higher than they had powered their study for. So just a few other things. There is no difference in the arms at baseline in gender, race, ethnicity, CD4 count, HIV viral load at randomization. And almost 93% of the HSIL treatment was office-based electrocautery. So they do high-res anoscopy and sort of freeze out or electrocautery out the lesions. And about 8% use either a topical 5FU or imiquimod. So I think the bottom line of this was that there was a 57% reduction in the risk of anal cancer when you underwent active treatment for your HSIL lesions. And there were 7 serious adverse events because, potentially these treatments may have an impact on the anal sphincter, cause, side effects like fecal leakage and other things that would be of significant concern. They saw only 7 in the study, of which 3 were pain, 3 were abscess, and 1 was ulceration. And there was 1 ulcer, I believe, or maybe it was an abscess, sorry, in the active monitoring arm for comparison. So those 7 were all in the active treatment arm. So I think in answer to the fundamental question of, does screening and treatment of anal lesions in people living with HIV reduce the risk of anal cancer? I think the answer was pretty definitively yes. And how does this impact our practice? So this does not address the utility of anal pap smears, which I think is something that all of us would really love to know, as all patients in this study were screened with high-resolution anoscopy. And there are still challenges with anal pap smears, in particular in getting them to match what the high-resolution anoscopy results would be. Second, clinical capacity currently, even in the United States, is unlikely to be able to support this strategy of high-resolution anoscopy for all patients, and the frequency of doing it is also not clear. The incidence was very high. The study was stopped early and underlines that this is really an important problem and one that we need to be thinking about in our patients. And then the final thing is that there's still actually plenty of room to improve on treatment because 9 cancers emerged in the active treatment arm. So either that means that the treatment itself wasn't fully addressing the lesion, or that there are other unappreciated lesions, or that we need to develop multimodal approaches. So I think despite these questions, this is a practice-changing result. And the way it changes my practice is that I think counseling about the follow-up and treatment of HSIL should reflect the certainty that now there really is utility to addressing high-grade squamous epithelial lesions found on anal cancer screening with high-resolution anoscopy, and that should be the clear message to our patients. I'll just pause here in case anyone has any comments or thoughts about this. And also because I meant for this to be interactive, not just me talking. So if anyone has anything they want to say, please feel free to unmute, or you can also put something in the chat. All right, well, I will continue.
Sorry, I had one question. I'm sorry. Did they look at who, how many of these folks were vaccinated against HPV?
So it's a great question. So the study only enrolled people over age 35. And so in particular, at the beginning of the study, which I think it started like I actually don't remember when it actually started, but it was very difficult to get the HPV vaccine once you were above 25. It's now easier to do that. So it did not address it. And I think it's a really important question in terms of it's likely that the utility will go down substantially once we have HPV vaccination, as has been recently reported for the dramatic impact on rates of cervical cancer.
Yeah. And they didn't report on LSIL.
No, so they were only, right. So there's still lots of unanswered questions. And, you know, when you think about sitting in a room with a patient, like, okay, so we don't really have a track to immediately refer for HSIL screening for high-res anoscopy. We usually do an anal pap and then, or if people have symptoms or a palpable lesion. So the recommendation from the discussion was to continue to do things like digital rectal exams and feel for palpable lesions and try to appropriately triage people to go for high-resolution anoscopy. But they were really mute on the, to my read of the presentation. Anyone please feel free to chime in on the utility of anal pap smears.
Yeah, thank you.
I think Joe Coe has a question as well. Joe?
I was just asking how frequently they did the HRA and did it change based upon previous HRAs?
So because they all had HSIL, I believe that the active monitoring and the treatment arm both had them every 6 months, but I would have to check. So it was relatively frequent. And that may also be why there were so many cancers identified in both arms. But again, one of the points of the discussion was that like clinical capacity right now just isn't there to offer this service to everyone living with HIV. But I think to Natasha's point, maybe if we focus on it as a current need for additional resourcing that may decrease over time, there could be an upfront investment that could actually expansion of capacity that doesn't have to be sustainable forever if we can increase vaccination rates for HPV. But okay, so I'll move on to the next thing I thought was interesting. So these are some studies looking at the use of cabotegravir long-acting for pre-exposure prophylaxis. So these are updates from HPTN 083 and 084 studies on the use of cabotegravir for pre-exposure prophylaxis. And just to remind everybody, so the FDA approved cabotegravir for injectable PrEP in December of 2021. So it's actually an option for our patients. So what were these studies? So HPTN 083, cab long acting for PrEP at 43 sites in 7 countries enrolled MSM and transgender women. HPTN 084 was cab LA for PrEP in cisgender women in the global south. And the data here that I'll talk about were presented by Rafi Landovitz in Abstract 95 for HPTN 083, including the blinded period of 3 years of follow-up and then 1 additional year of unblinded follow-up. So here's what they've previously shown. So at their initial stopping point analysis, which was presented at the AIDS 2020 meeting, there was a hazard ratio of 0.34 favoring cabotegravir over FTC-TDF for prevention of HIV. At their update last year at CROI, the hazard ratio was 0.32 favoring cabotegravir over FTC-TDF for prevention of HIV. Again, these are both from the HPTN 083 study. So what's the new data at this time? So when they looked out to the blinded period, the hazard ratio was 0.34 favoring cab. At the year 1 unblinded analyzed alone, the hazard ratio was 0.33. And in the post hoc, so an unplanned but post hoc combined analysis, the hazard ratio overall is 0.34 favoring cab over FTC-TDF. So I think one could characterize this as a remarkably stable hazard ratio that remains in favor of cabotegravir as pre-exposure prophylaxis over FTC-TDF. So a few notes, the unblinded period included a much higher infection incidence rate, and this was attributed to 2 things. So in the first was the global regions represented. So down here in the pie charts, you see that in the original blinded period, the US contributed as many as 47% of the person time years, whereas in the year one unblinded phase, Latin America substantially increased its representation, and also Asia. So areas with a much higher incidence of HIV were accounting for more of the person years, and the US had shrunk to about 22%. And then what's shown here on the right is the slides for which he showed the reduction in adherence. So in both the TDF and FTC arms, which are shown on the left here, you see an increase in the red, orange, and white areas, which are basically showing you people who were not at therapeutic dosing in their sub-cohort to look at tenofovir FTC adherence. And likewise, you don't see as good coverage of cabotegravir shots on the right side during the unblinded year. So as time goes on, people are not as adherent, and this may also influence the rates of infection in this unblinded year. So there were 2 additional infections in the cabotegravir LA arm, despite on-time dosing. So this means that they now have risen to a total of 7 breakthrough infections occurring despite on-time dosing. So this means they got their shots, they weren't delayed, they still developed HIV. This gives a rate of 0.15 per 100 person years. And they also reported for breakthrough infection on therapeutic dosing. And they had 3 new category DX cases. So D are their cases where they actually developed on treatment. They have a very standardized protocol for determining whether the infection developed while on treatment prior to exposure, or whether it was a missed infection at baseline type of thing, or whether it occurred in a lapse in therapy. The DX cases are 3 additional cases that occurred close to the time of dosing, but not quite on time. These all remain unexplained. We still don't know exactly why this is happening. So additional data from these studies will include an optional oral lead-in. Whether or not that's necessary looks less and less likely. The HIV RNA is a screening assay, and I'll comment on that in a minute, and then impact of earlier detection on the risk of INSTI resistance. And so that's the next thing I'll talk about. But just to finish up this, it continues to work very well, and it continues to have a substantial advantage over FTC TDF in prevention of HIV. However, it does have this sort of uncomfortable thing, which is that you can become infected while on therapeutic dosing, and we don't exactly know the reasons why for that. So I'll just talk about abstract 96 next, and then we can have a discussion about what this data means for us. So the premise of this part of the study was that cabotegravir suppresses virus replication and may delay HIV seroconversion, which may lead to delayed diagnosis when antibody testing is used, leading to a window of increased risk of developing INSTI resistance, so developing an integrase resistance mutation. So the study design here was that they used a lab-based, very low viral load INSTI genotyping assay, the kind of thing that we can do with, centrifuges and samples that you can't do in the clinical lab. And they're trying to pinpoint the exact time of emergence of INSTI resistance, and then determined based on the emergence, whether if you'd use a clinical viral load, you would have been able to capture that patient. So this is a way of saying whether or not using viral load screening during a cabotegravir PrEP approach is actually a good idea from a resistance standpoint. So they had 16 infections in their CAB arm, 4 which were at baseline, but then were started on dosing, and then 12 incident infections. 5 of these had INSTI resistance as based on monogram testing. So they had clinical resistance testing that showed they had integrase inhibitor resistance, and 2 were unable to be appropriately tested because their viral loads were so low during the study period that they couldn't amplify enough to get a clinical integrase resistance test. So they took those 7 people, and then they took them for their ultrasensitive genotyping assays in the lab. In 5 of these 7 cases, major resistance mutations were detected in the very low viral load samples, and use of an RNA assay would have detected the infections prior to the emergence of resistance mutations in these cases. So they went back and looked at the samples from prior visits and sent them for clinical viral loads. And in 5 of the cases, 4 of the major mutations and 2 who developed additional mutations would have been identified before the emergence of those mutations by a clinical viral load assay, which I think is really a strong argument for the use of viral load testing if you're using a CAB-LA PrEP approach. So the US package insert currently recommends that individuals must be tested for HIV infection prior to initiating CAB-LA or their oral CAB lead-in with each injection using a test approved for diagnosis of acute or primary HIV. So acute HIV includes usually a 4th generation, but also a viral load because of the potential for the antibody test not yet being positive. And then if a 4th generation antibody test is used in negative, then negative results should be confirmed with an RNA specific assay, even if the injection will be given prior to results availability. So what this means is, even if you're going to give the injection, do the viral load anyway. If 3 days later it's positive, you can then reassess your strategy. And 3 days is not long enough likely for integrase resistance to develop. So you're still within a window where you can likely intervene at the beginning and even during emergent infection while on treatment. So to me, I think this really suggests that nucleic acid screening is a safeguard against INSI resistance for individuals on CAB-LA for PrEP. They do make the point, and I think this is important, that this should not necessarily be required in a global setting, given the higher proven efficacy of this treatment. So the rate of developing these infections is low. It's lower than the rate of developing infection, period, on FTC-TDF. So to limit the use of this strategy globally may not be appropriate, because it will mean that more people will actually become infected with HIV if they're only given the option of FTC-TDF. So I think this is a very fine line to walk. And I think that it's one that I think is worth discussing. So I've seen some things in the chat. So Joyce, did you want to unmute and say, oh, and Joko asking, does insurance cover it? And does our clinic have the capacity for it for PrEP? So if anyone wants to comment on these results, either from the perspective of the updated results, it still works better, I think is the bottom line. There are still cases, very rare, 0.15 per 100 person years, where infection occurs on treatment. And then in terms of using a nucleic acid test, I think for us, the answer is yes, because we are a resourced setting. So Yuka's saying we need point of care HIV viral loads, totally. And Joyce, do you want to say anything about the availability in our clinic? Maybe
This is Kristen. So
oh,
it's
hey, Kristen.
Hey, how are y'all? It's not yet available. We do plan to take it to PNT here sometime soon, but we also are not yet sure of how insurances will cover it. We're still working through Cabenuva and getting that back off the ground with our wait list of patients. And so once we get into a good place of that, we'll be able to build on the current workflow of Cabenuva and then offer cabotegravir for our patients.
Kristen, for treatment with CAB, where are we for that going live? Not for PrEP, but for actual treatment.
So we paused things for a couple of months just due to some shortages in staff. We're starting to kind of look at our wait list again and tackle some of those patients. We are trying not to kind of overwhelm the nurse that's working on it, but I think we've started new starts, about 7 new starts here recently. So we're starting again. It's just kind of slowly ramping back up.
Thank you.
Mm-hmm.
So, and Yuka's saying we're not quite that close to having a point of care HIV viral load, but I do think the take home message for me is that should anyone be on CAB-LA for PrEP in my practice, I will send a viral load, whether or not I won't hold the injection, but I would send a viral load because I do think that strategy will protect patients from potential emergent INSI resistance, because you can add to their therapy and give them more than single drug therapy.
I mean, without complicating things, the other problem right now is that molecular tests are not considered CLIA waived in the state of Maryland, which makes it even more complicated, but we'll see what we can do for point of care. That's correct.
Yeah, that is a substantial barrier. And I think it's important though, just to, I'm kind of fascinated by these failures on treatment. And I think maybe after this next little discussion, we can harass Ethel to talk about it a little bit, but they're very infrequent, and the net hazard ratio still favors the use of this agent. And again, the emergent INSTI resistance is also a pain, but it's infrequent. And in general, the strategy is favored in a global, in a population-based approach. So the next abstract I thought I'd talk about was just a poster actually, but it was from Atlas 2M. So this is the study of cabenuva, cabotegravir rilpivirine. And the goal of this study was to look at Q4 versus Q8 week dosing. So it's phase 3B, randomized, multi-center, parallel group, non-inferiority, open label study. And they included participants both from their original Q4 week phase 3 study, from the control arm of that Q4 week phase study, and then additional participants who were on oral therapy at the time prior to enrollment. And they were randomized 1-to-1 to lead in, and then to cabotegravir every 4 weeks or cabotegravir every 8 weeks. And it was 522, 523. So it was a substantially sized study. So I just copied some of the pearls from the poster. This was presented by Turner Overton. So withdrawal by the participant was more common in the Q4 week arm than in the Q8 week arm. And the most common reasons for withdrawal by participant include the frequency of visits. So clearly the 4 weeks is less favored than 8 weeks, I think, in what is a shock to probably no one. And the intolerability of injections was also much more notable for those in the Q4, not much more, but more notable for those in the Q4 week arm, with 8 of them reporting that versus 1 in the Q8 week arm. In total, through week 152, 13 of these participants had confirmed virologic failure. That was 11 of them in the Q8 week arm and 2 of them in the Q4 week arm. So the percentage of confirmed virologic failure was 2% in the Q8 week arm and less than 1% in the Q4 week arm. So a few more details about the confirmed virologic failures. So they occurred by week 48 in 77% of the patients. So most of them within the first year of treatment. 6 out of 10 had more than either 2 or more baseline risk factors, which included a proviral resistance to rilpivirine, which was not part of the screening, HIV subtype A infection, or a BMI more than 30. And all of those have been reported to be associated with an increased risk of failure of this regimen. None of the participants with confirmed virologic failure had injection visits that were 7 days later or more than the scheduled visit date. So these were not failures due to delays in dosing, which again, I think is important to remember. And 12 out of the 13 of the confirmed virologic failures resuppressed an alternative regimen, with one participant who struggled to be adherent to a PI-based regimen who was unable to resuppress. So the overall results, so Q8 week was non-inferior to Q4 week at week 152. There was more dropout in the Q4 week by participants because of the frequency of visits and intolerability of injections, and slightly more confirmed virologic failure in the Q8 week dosing, along with these higher patient satisfaction scores and less withdrawal. In the failures, most occurred before week 48, and none of the failures had delayed injections. Risk factors for failure may include proviral rilpivirine resistance associated mutations, HIV subtype A, and a BMI more than 30. So I think the importance of this study is that it confirms the efficacy for most, but with a few exceptions, and an informed discussion of the patient should be part of the use of this agent. But I'd love to hear, Ethel, I did see you join, so I hate to put you on the spot, but I don't know if you wanted to comment on what your thoughts are about why we might be observing these failures, because they are definitely more frequent in the Q8 week arm. Although, again, still overall, more people remain suppressed on the regimen in the Q8 week arm.
Yeah, I think one of the statistics that you mentioned to me, Eileen, that I think is really compelling is 2 out of 523 compared to 11 out of 522. That's a 1 at week 152 at 3 years out. That's a 1 in 40 in the Q8 week arm versus 1 in 200 in the Q4 week arm risk of virologic failure. And that's concerning to me that seems like a very potent difference. It's small numbers, but I guess my question is just what percentage of the time it's due to PK factors and what percentage of the time it's due to other factors. I think there's this component of variability from injection to injection within the same person, regardless of their BMI, subtype, et cetera, but just differences in PK within from injection to injection that I think is something that raises the prospect, at least in my own mind, of the potential utility of therapeutic drug monitoring. But that only would that only would help with the people whose failure was due to PK. And I think that it's not always. So I agree that there's, in my mind, a little bit of a concern based on this, but the FDA was certainly convinced enough to approve Q8-week dosing. And indeed, that was the only thing approved in Europe, with a little bit of subsequent clamor to at least have the option of Q4 weeks that could be discussed with patients. But I think it's intriguing. I think it needs to be explored.
Yeah, so Ethel's referencing that the European Drug Approval Agency only approved Q8-week dosing, and the US FDA approval was updated to Q8-week dosing recently. I mean, I think I would say taking a totally untested off-label approach, I'd love to do Q4 week for the first year and then go to Q8 week, totally untested and not based on any actual empirical data, but I also don't know that that will be tested.
Although I wonder if you could look at that in the people in Atlas 2 who transitioned
from Q4 to Q8. That's a good question.
That would be an interesting subgroup.
Yeah, and I'm seeing some things from Kristen and others in the chat about the availability of Cabenuva for the Q8 week dosing. And then at Baltimore County Health Department, still there's someone who initiated on cabrolpiperine, and insurance denied the monthly dosing, so they will need to do the Q8 week dosing. So this is probably not shocking based on both the cost of the drug and the cost of the visits. Yeah, this is due to financial incentivization. So, I mean, I think the bottom line is, again, it works really well. Like, the results are very good. It's just, I think many of us have been used to for years telling people that if they take their medications, they will not have virologic failure. And it's sort of a brave new world to have patients who could be totally adherent to the regimens we prescribe and potentially still have a low but present rate of virologic failure. So I open up the floor to anybody else who wants to comment. I have not yet used it, so I have no direct experience.
Do we think this? Oh, go ahead, Richard.
Oh, I was just going to say, particularly given the comment from Sarah, do you think with the FDA approval of Q8 week, like this one, we're just not going to have an option?
I think it's possible. I think we may be transformed into Europe with worse pastries. But in terms of, yeah, if insurance companies can say this is approved at this frequency, it's going to be hard to make a theoretical argument to do Q4. Steve, did you have a comment?
Well, we definitely have better backyard lawns here. It's probably way beyond the point they could do this, but is this the type of thing that could be overcome with a little bit higher dosing at Q8? Then maybe that's an Ethel question, or anybody.
Yeah, so a lot of their dosing, especially their lead-in, their loading for those first 2-3 months is based on modeling. And I think it's a good question. The kinetics are really quite flat. So getting your peak up and just, I mean, that means that you fall below trough much later. But I think they did alter like the load for the Q8 week dosing in what eventually was approved by the FDA, all based on modeling. But I think these are the sorts of things that should be studied. The appropriate dosing is something that should be looked at in real patients rather than just models.
Thanks.
Yeah.
And I really like Sarah's suggestion in the chat about when to schedule people.
Yeah.
And this has come up. So I've given a lot of people Q4 week Cabenuva and had them suppress and had them do great. We had one person who had kind of, issues with perhaps persistent low-grade viremia, and we were thinking, can we strategically have them come in still within the injection window, but a little bit earlier, so still per protocol, but skew towards Q3 weeks each injection, and I think it's a good thought. How do we game the system? How do we game the injection windows? But I really think it would be nice to be able to get drug levels too in clinical practice. So that's something that I think needs to be thought about and worked on as well.
And it may also be a niche, a niche for the proviral genotype, which, I don't feel like is something that's dramatically enhanced my clinical practice in most settings. But if you did have a real piperine-associated resistance mutation on your proviral genotype, that would affect my counseling. Maybe would go into a prior authorization for Q4 weeks, although I don't know that it would get supported. Any standard genotyping assay will tell you the HIV subtype of your patient, so you can always review that if they've ever had a genotype done. The vast majority of our patients will be subtype B, but some patients who come from sub-Saharan Africa to our clinical settings will have subtype A, and some people just have subtype A. So I guess among the risk factors that would push us to try to negotiate with insurance companies, we can easily assess BMI and HIV subtype if there's ever been a genotype, and we can also fairly easily send a proviral genotype. And I think most of the time insurance would cover that if it was felt to be clinically indicated. So I think maybe those are three things we could use to increase our confidence.
Yeah, that's a really smart approach, and I think doing that prospectively rather than retrospectively trying to figure out the virologic failures is the right approach.
All right, so we will continue to see how the Cabenuva trials and in real life work out. So let's just talk briefly then. The last thing that I was going to cover before I turn things over to Richard is the NADIA results. So, and I thought I'd just take a step back. So NADIA was actually published last year in the New England Journal, the original results, which were the week 46 data. And so what this trial was is, it's like a cute acronym for nucleoside alternative and second line. And anyway, it's a practical trial to assess the WHO recommendations currently for change in regimen after failing your first line option in the absence of genotype testing. So this is for global settings, mostly sub-Saharan Africa, where people come in with failing on a regimen and there are standardized recommendations to what you should change to. And so there were two questions they were trying to answer with this study. Number one, is dolutegravir equivalent to darunavir in this setting? Failed something, changing to something else. Could that something else be dolutegravir, or does it need to be darunavir? There have been some prior studies that have compared to less, efficacious PIs, so it really hasn't been kind of really proven whether our best PI and dolutegravir are on the same footing. And then the second question is, should a change to AZT be recommended? So in a lot of these settings, after you fail your first line regimen with tenofovir, it's recommended to change to combivir, so AZT 3TC, assuming that there's some resistance that might be more amenable, in particular the K65R. K65R is the signature tenofovir mutation. There's some data to suggest it emerges more frequently in viral subtypes outside of subtype B, so more common in sub-Saharan Africa than it is in our patient populations. And it really has the highest penalty for tenofovir as a single mutation, on par with, having the TAM2 pathway of higher tenofovir cross resistance. So the question of whether or not we should, and also K65R makes AZT hyper susceptibility. So AZT is more efficacious when a patient has a K65R. Although, as I usually teach the fellows, like pro tip, still don't use it because of the toxicity. So regardless, that's what this trial was supposed to test. So the paper results, which were published last year, showed high rates of viral suppression on both regimens. So whether you were on darunavir or dolutegravir, and showed high rates of viral suppression whether you were on the tenofovir-based regimen or the AZT-based regimen, even when resistance testing suggested that there were no active nucleosides in the regimen. And so we'll drill down a little bit on what that means with these updated results. So what they presented this year was the 96-week results. And to be honest, I thought this paper was great. I was excited about it. I also thought it was 1 year. And as Joyce brought up on one of our prior conferences, the failure rates of monotherapy are not in the first, immediately after the switch. They take some time to show up. And so I wasn't convinced that we weren't looking at monotherapy in at least some of these study participants. So here they're presenting the 96-week data. So it's 464 patients at 7 sub-Saharan African sites. The trial is predominantly female at 61%. 51% have a CD4 count less than 200, and 28% have a viral load greater than 100,000, so real disease. 92% have resistance to 3TC with the M184V or I. 58% have intermediate to high resistance to tenofovir, and that is almost all K65R. I have to break down on a piece of paper here, but it's between 47 and 53% of the patients had a K65R mutation with resistance to tenofovir. So at week 96, viral load less than 400 in almost 90% of the dolutegravir and 87% of the darunavir, which showed non-inferiority of either regimen for that first randomization. Then within those two groups, they also had randomization to either tenofovir or AZT. Viral load less than 400 in about 92% of the tenofovir group and 85% of the AZT group, which led to an estimate of tenofovir superiority. So overall, all of these regimens were efficacious. It doesn't matter whether your backbone is dolutegravir or darunavir, and you shouldn't use AZT, is sort of the bottom line of the efficacy studies, even when there's a tenofovir mutation, K65R, which will be almost always in combination with an M184V, since 93% of the patients had M184Vs. So that is a strong argument that AZT has no role in the world. And then the next question is, what is the role of resistance testing, and what are we looking at in terms of, are these nucleosides still doing something or not? I will note, for those of us who still have, emotional allegiances to darunavir, there was more virologic failure in the dolutegravir group. So there were 7 cases, 5 of which occurred in the AZT backbone group. So dolutegravir AZT3TC was definitely a risk for failure in the dolutegravir group, but those failures did occur with resistance. There was no failures with resistance in the darunavir group. So again, argues that darunavir is special still, even though for many reasons I have to let go of the specialness now that dolutegravir and Biktarvy are so efficacious. It does have a slightly different barrier to resistance, but in general, dolutegravir performed very well. And if you only look at those cases where dolutegravir was used with TDF-FTC, there were only 2 cases of resistance compared to 0 in the darunavir arm. So those were the major data points. And then to get to this question of, is this monotherapy, I was looking through the literature at some studies, and this is a meta-analysis that looked at mono and dual therapy in dolutegravir-based regimens, and looking at the rates of virologic failure. And the top part here is all the monotherapy studies, and the bottom part here is all the dual therapy studies. So this is part of the data that supported dolutegravir, rilpivirine, dolutegravir 3TC as therapies, because in general, the rates of failure are much, much lower than the monotherapy studies that were favored by our friendly European colleagues in many, many studies. So just to zoom in here on their summarized rates of confirmed virologic failure, that in monotherapy regimens, the dark blue is 24 weeks and the pale blue is 48 weeks, that they're looking at 10% confirmed virologic failure in monotherapy, where they're down at 1 to 2% in the dual therapy group. So I think that now this is a different definition than what's used in the NADIA trial, looking at viral load less than 400, which they're looking at, patients who adhered and failed this regimen. So the percentages look about the same, but this is actually a much higher, to my mind, percentage of failure than what is seen in the NADIA study, which is a real world virologic suppression assay where you are achieving rates of clinical suppression that are akin to those seen with standard triple therapy. So I think the updates from the 96 weeks, so now, almost 2 years of study, dolutegravir and darunavir both work well as second-line agents in the global setting. Slightly higher rate of dolutegravir failure with resistance, but this was predominantly in the AZT group. And I think this really pushes us to reconsider the "you're dead to me" approaches, specifically for the class of nucleoside resistance. And we don't have data for that in other settings, but I think you could argue that this study does show that there is residual activity of nucleosides, even when there is documented resistance, and that this may mean that some therapies are actually an option, whereas previously we were thinking that they would no longer be useful in the agents. So I'm going to stop sharing because that was my last slide, but maybe we can talk a little bit about these results. So, and Joyce, I don't know if you have a microphone or if do you want to just unmute?
Hi, sorry, I've been kind of in and out. I had a patient run over and then I got a phone call. But my understanding was with those monotherapy studies, some of them were just sort of cohorts from real world things that were happening. And so, I think that's something to consider as well, just in terms of the difference of that studying monotherapy in that situation versus studying dual therapy in a clinical trial.
No, agreed. And I think, I'm still not totally comfortable with this, but I think, it's pretty, like they had very high percentages of K65Rs, right? So high percentages of people with, and all of them essentially had M184s. So essentially really potent nuke resistance and still with very high rates of virologic suppression, regardless of dolutegravir or darunavir, in a patient population that had already failed the first line therapy. Right, that's the other sort of like step back again, like who are we talking about? We're talking about people who already failed once. And so, I mean, from a global practical perspective, I think it's a strong argument to still use tenofovir clearly, but also that you don't have to do more complex regimens for your second line. And in terms of when you're sitting with your patient, they have a K65R and an M184V and you're deciding what to put them on. This, first of all, doesn't test Biktarvy, but I think there is a possibility where if you really felt like someone could only tolerate a single pill, you could still do an option of either, I guess in this case, I would favor Simtusa for that patient and assume and hope that this would suggest that I had, a high probability of achieving virologic suppression, even though you could argue it was functional monotherapy. Anybody else have thoughts or comments? And then also, Richard, please. Oh, I left you 4 minutes. Oh my gosh.
Yeah, well, I'm gonna make a command decision here. I think, I know people leave us to go to the clinic and so on and so forth at 1 o'clock. And what I need to present probably is going to be around 10 minutes. So why don't we do the following? What I was going to present really are epidemiologic studies that don't have as direct impact, I think, on our clinical care. I think they're very useful, they're very important. And why don't we, if you don't mind, we'll take these 4 studies, maybe 5, and move them to a later meeting where I think they'll still be impactful, but they don't have such an immediate clinical effect. You did a great job, by the way. I am glad you took the whole hour.
I wasn't watching the time closely enough, but yeah, but no, Richard has some really great studies to follow up on too. So this wasn't all that there was at CROI. So we'll definitely schedule that for an upcoming session and go over some of the other updates from CROI. But in any case, thanks all for your participation and thoughts. And David Black, I hope you send me a thoughtful email later about some of these studies, as you often do.
Can I ask you a question, Eileen, since we have 3 minutes?
Yeah.
About the NADIA study, and whether you think tolerability of AZT might have had an effect on adherence that might have affected the emergence of breakthrough and resistance.
Yeah, I totally think so. I mean, I think it is not an easy drug to take, and it has way more cost than tenofovir for the average patient, which is why even in the past, because of the hypersusceptibility to the known hypersusceptibility, my practice was not to use it because I didn't think that benefit would really outweigh the toxicities. And so I think that may have contributed. It's hard to separate that from its actual efficacy in terms of a perfectly adherent patient, because the PK is less forgiving. So that plays into how efficacious it would be. So to your point, it may just be that it's a less palatable and more difficult drug to take and has more toxicities, but I think that sort of either way, I think the WHO should change that recommendation. Not that they're asking me.
You'll add it to the list of "You're dead to me." Is that right?
Yeah, that one actually goes on your
last week. Back of the year last week, and now AZT this week. So the A's are out.
Well, but it's funny though, because at the same time, I'm making this argument that they're magical, right? That unlike other classes of drug, the ones FTC and TDF at least do seem to have some activity even when it would be predicted not to. And there is an argument for this, to the size of the molecules, to access to compartments, the potential induction of innate immune responses within cells. There's all sorts of things about it that might be true. But at this point, I'll just say we don't have this data for other classes of drug for efficacy in the face of resistance mutations. But this does. I mean, and to Joyce's point, the more time we get, the more we'll see whether this is monotherapy or not.
Yeah, just to say also that I think if it's true of TDF, it's going to be even more true of TAF, which has the 4-fold higher intracellular concentrations that maybe can overcome the K65R. So different times.
Yeah, even more beneficial. Although I didn't present the weight gain data, so. Maybe everything will be dead to me by the end.
Well, thank you very much, Eileen. That was outstanding. And thank everyone for attending. We'll have a briefer part 2 of this when we can schedule a few weeks.
Thanks, everybody. Have a great weekend.
Thanks, Eileen.